So, welcome everyone to Let's Code Together. My name's Jane Knight. I'm a clinical associate with the Medra MSSO, and I'd also like to welcome my colleague, Dr. Caroline Wilson.
Hello to everyone. Welcome.
Welcome. And there we are. I'll just put my camera on to say hello to you all before we continue with the session.
Me too. Still in blue screen.
So the first slide is just an explanation that Medra was developed in the mid-1990s. It was an ICH initiative, and at the time the MSSO was put in place to maintain and distribute Medra. The activities of the MSSO are overseen by a management committee with representatives from across the ICH regions, with the industry and the regulatory authorities. The material that you'll see today is the property of ICH, as is Medra itself. You're welcome to use some of the examples, but you must quote ICH as owners of the material, and if you change things, then it's your responsibility to note where you've made changes. And there aren't any third-party slides today. In case any of you are ask the question, we don't make the slides available from the Let's Code Together sessions because they are more of workshop with discussion as the value of the session rather than the slides themselves. But the recordings will be available on YouTube. So, as I mentioned, it is a workshop. We want you to join in, share with us, use the questions panel to ask your questions or make comments. Sometimes we don't agree on the term selection, and in the interest of time, we agree to disagree. So we will give you what we believe is the most appropriate answer, but we can't also take requests to code specific verbatim terms in the questions. So just a note there about the questions. However, at the end, there will be a survey, and in the survey, there's an option for you to propose new examples for us to consider at future sessions. But please make sure that these are of general interest to the wider audience, not related to a niche therapeutic area. Another point there is that just to point out, we have got a number of examples that we're using today, which have come from previous attendees. This is details of the polling software. So I mentioned that we'll be using Poll Everywhere, and you can join the polls by either two ways. First, the easiest way is to scan the QR code that you see on the slide, and we can activate the QR code during the polls in the future during the session. Alternatively, if you would prefer to use your browser on your computer, you can open a browser and you can go to pollev.com. So that's all you need to type into the URL bar, pollev.com. So you open your browser, so Edge or Safari or Chrome, and you then type this in. It takes you to the presentation. You enter my name, Jane Knight 855 is the username. It's completely anonymous, and that will link you to it. So I'll just give you a moment to do that. I know some people say we're a bit quick with this, so I'll just leave that on for a moment while you all log on. Okay, everyone okay with that? So where are you joining from today? Here's a map. I know it's quite small on your screen. See if you can tell us where you are. Well, I'm seeing France, Portugal, Spain, North America, late at night or early in the morning for you there. India, welcome. Wherever you are, somebody's quite sure. Korea, South Korea, Australia, Philippines, South Africa. Anyone else, Caroline? Would you like to?
Lots of people from China we have, the Philippines. So welcome, everyone.
Welcome, wherever you are. So these are the details for the web-based browser. You can access the web-based browser from our website. You see there's a quick link on the top right-hand side. And this is just temporary demonstration credentials. If you don't have access to a browser, you can use this one. But if you have access to your own browser, you don't need this. This is only if you have no other access for the session. So that you might want to take a snapshot And Carol Ann's going to put the details in the chat for us, so you can go back to refer at any time. So with challenging verbatim terms, there may not always be an exact match, and sometimes there's more than one possible approach. Points to consider document itself. The term selection document also offers us options in places. And sometimes it's a matter that we all can look at a verbatim term and we can understand that term differently. This is what causes us a challenge sometimes in coding. So when we are coding, what we're doing is we represent the events that have been reported by what we like to call a best approximation. But overall, the golden rule we say is that we must always code as reported without making any assumptions about the reported term and its meaning. Here's an example. We always have a picture in these sessions. So this one shows an event here, just like reported events. They can be understood differently by different people. And here we see in the cartoon, we've got the man in the car who's blaming, as you can see, there's a lot of people all around him and he's blaming what he thinks is a marathon, people running without realizing that there's some kind of monster or dinosaur chasing. So it shows how that situation can be interpreted differently. And verbatim terms are exactly the same. Even Carol Ann and I sometimes look at examples and we find that we can understand those examples differently. So this is why these sessions can be valuable to hear different perspectives. We use medical judgment, and it's all a balance between having coding rules for consistency and then using medical judgment to manage the risk to patients. Medical references can be helpful to us in understanding the reports and making those coding decisions. And you'll see today we share some of the references with you that we use typically when coding and understanding terms. Sometimes it might even be necessary to request that a new term is added to a future release of MEDRA because the reported concept doesn't exist in the current version. So, having said all that, all the introduction, let's code together. And I'll hand over to you, Carol Ann, for the first two examples.
Thank you, Jane. Now, let me start with our exercises and coding challenges today. The first verbatim is quite complex. We are told that the patient has a predisposition to thrombophilia and a mutation in plasma link. Do we understand what has been reported, or do we miss information here? And are the two findings related to each other so that we have to split code? What do you think? Jane has also put this verbatim in the chat so that you can see it. How would you approach this verbatim? Would you seek clarification, or which LLT or LLTs would you select? What would you do? Would you select predisposition to disease, thrombophilia, congenital thrombophilia, just thrombosis, gene mutation, acquired gene mutation, coagulation factor mutation, asymptomatic gene carrier, or would you seek clarification from the reporter? What would you do? I see that many of you are voting already. Just wait a moment. So this is one of the examples that we had prepared for the last session that we carried over to this one. So I've already got 100 responses, so let us check what you're voting for. Here we are. So most of you are going for predisposition to disease, but others to thrombophilia, also congenital thrombophilia, and others would seek clarification from the reporter. So we have split of opinions. Others would also code the gene mutation and split code. Let me close the poll here. Here we are. And look into the Dorlins, because here we will find some definitions which are relevant for understanding the reported condition. So a predisposition is a latent susceptibility to disease. It may be activated under certain conditions as by stress. Then the explanation for the term thrombophilia. The ending philia in Greek means tendency towards, meaning that thrombophilia stands for a tendency for the occurrence of thrombosis. In our case, based on the plasma link mutation, a mutation in any clotting, anticoagulant, or thrombolytic factor. The factor affected by the mutation is not specified in the verbatim. And hypercoagulability is the state of being more readily coagulated than normal, so somehow a synonym for thrombophilia. And here the definition of a gene carrier. In genetics, a carrier is an individual who is heterozygous for a recessive gene and thus does not express the recessive phenotype but can transmit it to offspring. So this doesn't fit for the given verbatim. Proposed term in the poll was asymptomatic gene carrier, but in our case, not just a gene carrier, but a predisposition to thrombophilia was reported based on a mutation. Now let me switch to my browser here. Here we are. I have to log in again with my credentials. Here we are. And if I look for predisposition, oops, and search, then we find predisposition to disease. If I click on it, I will see the hierarchy in the term details window. Here it's grouped under general disorders and administration site conditions. So very general assignment, because we don't know whether this is a congenital disorder or whether it's an acquired disease susceptibility. So predisposition to disease is grouped under disease susceptibility. Now, what about thrombophilia? Here we are, thrombophilia. Again, let me check the hierarchy. It's grouped under blood and lymphatic system disorders. We also have a congenital thrombophilia that is, of course, grouped under congenital with a secondary link to blood and lymphatic system disorders. And then we have the gene mutation that was reported. It was just a plasma link mutation. It was not specified. Here we are. And if I again click on this term, you see the hierarchy here, gene mutation, same PT, and it's grouped under congenital with no secondary linkage because it does not contain additional information that would allow for any manifestation site. So this was the acquired gene mutation is another option. If I look into the contains search results, this will be the first term that we see here, acquired gene mutation, and then many terms that relate to very specific gene mutations. Acquired gene mutation, of course, is not grouped. It's still grouped in the congenital SOC. Here it is. So this would be also an option. It's under gene mutations, other alterations, because it's still a gene mutation. That's why it's a congenital. It's considered a congenital, familiar, and genetic disorder. It's a genetic disorder. It may not be congenital, but it's a genetic disorder. And then we have one of the options was coagulation factor mutation. And here it is. This is a specific term, and you see that it's grouped again under congenital SOC, but also under blood and lymphatic system disorders, a secondary linkage, because this coagulation factor mutation, of course, allows for assignment of a secondary linkage, in this instance, blood and lymphatic system disorders. So a coagulation factor mutation, if we would assign this LLT, this would be an assumption, because we also only are told that there is a plasma link mutation. This could also be a mutation leading to protein C or protein S deficiency, for instance. So this would be an assumption. This one would not be suitable for our coding purposes. And we also saw that the other option that we had in our poll, LLT asymptomatic gene carrier, would not appropriate either, based on the definition that we saw. So what shall we do here? First of all, we must always clearly distinguish between a diagnosis like a thrombosis and a thrombosis tendency. So assignment of the LLT and PT thrombosis would not be appropriate in this instance, because what is reported is just a thrombosis tendency, a predisposition, a thrombophilia. If specifics of the mutation and type of thrombophilia is relevant for the product in question, then it would be recommendable to query to find out the exact type of the mutation, the etiology of the thrombophilia, and many of you have voted to query this term. And we should always reference textbooks and search for the best approximation if no further information is received about the type of mutation and subsequent thrombophilia. Our final suggestion is to seek clarification if the exact etiology of thrombophilia is relevant for the product. And otherwise, or if no clarification is obtained, we would suggest to go to LAT congenital thrombophilia under the same, under PT congenital hypercoagulation. Because there is a mutation in the plasma link, so it's definitely a genetic disorder. That's why we consider this a congenital thrombophilia and assign a more specific term than just thrombophilia. In our view here, no splitting is required, so we would not code to thrombophilia and gene mutation, but we would capture everything with one term, that is congenital thrombophilia. So with this, we would follow the MEDVA classification of PT gene mutation, which is grouped in SOC congenital. Are there comments or questions, Jane?
No, Caroline, there's no comments on this so far.
Okay, maybe you are still thinking about it. Then please raise your questions afterwards. We can go back and discuss whatever your questions are or comments are. And otherwise, I will continue here. This is our next example. It's more straightforward. A patient thought he had a blood clot, and after some investigations, then the physician confirmed he had a DVT. What exactly is being reported? How would you approach this verbatim? Is there a need for clarification? Or do we have to split? What would be the most appropriate LLTs or LLT then? So again, Jane has put this in the chat, the verbatim. How would you approach this? Which LLT or LLTs would you select? DVT, yes. So DVT seems to be the favorite solution. Anybody voting for splitting? I see you're all experienced coders. Deep vein thrombosis, yes. Seek clarification. DVT. So the vast majority is going for DVT or deep vein thrombosis. Let me close this and let me show you in the browser again. Thank you for joining. Here we are. If I go with blood clot, this was what has been reported by the patient. So he was suspecting a blood clot. If I go for that, clot blood is available in MEDRA, and it's just grouped under PT thrombosis because it does not contain any information about the site, the affected site of the thrombosis. But of course, DVT is more specific. So let us search for DVT. It's available in MEDRA, so it's considered an unambiguous acronym, and it's grouped, of course, under PT deep vein thrombosis. So much more specific in this instance than the blood clot that is just grouped under PT thrombosis. There were no other suggestions, so nothing we should look for in MEDRA. Let us first now look into the ICH guidance for MEDRA term selection, the points to consider document, because the verbatim states that the patient thought that he had a blood clot. And after the investigations by the physician, it was then confirmed that he had suffered a DVT. So the final diagnosis is the DVT. But do we have to capture the blood clot in addition? Well, we don't have to, because we are told that if two conditions are reported in combination and one is more specific than the other, select a term for the more specific condition. And the arrhythmia example in the document is similar to what we saw in our example. Arrhythmia due to atrial fibrillation. So we have a general diagnosis and then a specification of the arrhythmia. And here we are asked to code to LLT atrial fibrillation. So to capture the most specific information. So look into the PTC guidance and your in-house coding conventions to see how to handle similar combination terms. Do not split code verbatims which contain both a general and a more specific information for the same medical condition. So here we have thrombosis and DVT, or in the example taken from the PTC document, we had an arrhythmia that was further specified as atrial fibrillation. So both are connected. The umbrella term is the arrhythmia or the thrombosis, but these diagnoses were further specified. So we should only select the most specific LLT to capture the reported finding in such instances. So here our final suggestion. We would code to LLT DVT following the wording of the verbatim, and this is grouped under PT deep vein thrombosis. Are there any questions, related questions?
No,
Jane?
Carol-Ann, no comments or questions on these at all. Has anyone got any thoughts on it? You're welcome to share with us.
So I think this was quite straightforward. Most of you went for the DVT or deep vein thrombosis, so you already knew how to approach this verbatim. The other one was a little more complicated, but it seems that you also would approach the verbatim in the same way as Jane and I did. With this, then I hand over to you, Jane, again.
Thank you very much, Carol-Ann. Thank you. Let me share my... Okay, so can you see my slides now?
Yes, I can.
So this next example is taking product in water because of its bitter taste. And we've just got a note here that sublingual administration is required in the label. Now, that's quite an important thing to have in together with this verbatim term. So what is being reported here? Well, the patient, as we're told very clearly, that they're taking it in water because the patient says it has a bitter taste. Do we need more information about this? Do we need to split it? And what would there be the most appropriate LLT or LLTs? So what do we have here? Have we got is it a product quality issue? Is it a product complaint? Is it a medication error? What exactly is it? Is it a product use issue? Some of the terms you may have heard us talk about in other areas. So what would you select here? Which would you think? We've made your life a little bit easier by giving you a multiple choice again. So you can, is it medication aftertaste, dislike of product taste? Is the product taste abnormal? Was it the drug administered via an inappropriate route? Was it misuse of the drug intentionally? Intentional use by incorrect route? Or would you want clarification? can see a number of you are voting. I'll just show the QR code again, because I noticed a couple of you were responding in the questions rather than there. So hopefully you can still carry on responding while I just show that. So the easiest way, if you haven't joined the poll, is to scan this with your mobile phone. But you can also log on with the details in the chat via a browser if you don't want to use your phone in the office, if you're in an office. So I see we've got quite a few votes there. You can select multiple, so there's quite a number of you online today, so feel free to join the votes. Let's see how you're doing with your thoughts so far. So the most popular is intentional use by incorrect route. Well, that would seem to capture what's been reported, isn't it? Keep it simple. But what else? What other options have you selected? Drug administered via an inappropriate route. So that seems like it's slightly less specific version of the other one, doesn't specify intentionally. And then dislike of product taste is the other one that you're favouring there, dislike of product taste. And not so many of you are saying that the product taste is abnormal. So have a look at these two LLTs and the difference in the voting, and we're going to talk about those two shortly. So we've got two things, haven't we, here? We've got the issue of the taste, and we've got the wrong route or the inappropriate route, whether that was, we can capture intentional on that. So here's the final vote. The most popular choice was intentional use by incorrect route. And then some of you are also capturing the dislike of product taste being the most popular. And then a few of you have gone for drug administered via inappropriate route. So let's have a look at what we're told in the points to consider. So one of the terms I gave you in the multiple choice was intentional misuse. So if this phrase is new to you, let's have a look and see what the points to consider says. For the purposes of term selection and analysis of MEDRA-coded data, misuse is the intentional use for a therapeutic purpose by a patient or consumer of a product. It could be over the counter or prescription, but it's something which is other than as prescribed, not in accordance with the authorized product information. Now think back to what we were told, and Carol Ann's put the example in the chat for you if you've forgotten it. The patient was taking it in water because they didn't like the bitter taste, because of the bitter taste. And it was in the label that it should be, it was in the label that was the wrong route. Let me have a look at the exact wording. Sublingual administration was in the label. So what we're being told then would fit with this definition of misuse. So the patient is taking it for therapeutic purposes, but they're doing so in a way which is not in accordance with the authorized product information. So in other words, the label. Another point from this time in the points to consider companion document, which goes into more detail. And one of the areas that it does cover in the companion document is product quality issues. So this gives us some background information into how we can regard the product. Is it a product quality issue? So other important concepts that may be reported in a product quality monitoring system include consumer preference complaints, in which the reporter makes no allegation against the product quality, but communicates dissatisfaction with the product or the packaging design. Well, that would fit with what we've been told about the patient found that had a bitter taste. So we haven't been told that there's a defect with the product, just that the patient had a preference here, consumer preference. So that would fit. So we could be looking for a term from the product quality area within MEDRA, or perhaps not. We're looking for a consumer preference, aren't we? So let's browse. So we'll go now to my browser. Here we are. So let's have a look first of all for, what should we look for? Let's have a look for the product taste. Let's start with this product taste and see what we can, just to get us into the right area. Let's see what we've got. So we've got an LLT. We saw it in our multiple choice: dislike of product taste, product aftertaste, product taste abnormal, and peculiar taste of pharmacy. So these are the options that come up when I look for something around the product taste. So dislike would seem to fit with what we've been told, the scenario. And let's have a look at the hierarchy of that. That has a PT of product use complaint, which is in the of medication errors, product use errors, and issues. Now remember, this HLT captures not just errors, also issues. So this could be an issue, and this is not therefore a defect within the product use or product issues SOC. If we have a look here, we've got product taste abnormal is the other one that we had in our multiple choice. And I've expanded the hierarchy, and we can see here that this is product taste abnormal, product physical issues. So this is suggesting that there's something wrong, because it's within the product quality section within product issues. And we saw there in our points to consider companion document, the note was that when a consumer has a preference, it doesn't necessarily mean that there is a defect or a quality issue going on. So we need to be careful when we select the LLT that we choose for the taste issue. So I'm just showing you these two here. So if I look at this product use complaint, right-hand click, I can go to my browser, have a look around to look at the brothers and sisters of it to see the taste term. So it's under a whole section of product use complaint under the PT, and we've got dislike of product taste and some others like complaining about the packaging, difficulty swallowing or difficulty administering the drug, or it being too hard to chew. So there's some others, but dislike of product taste would seem to capture quite nicely what we've been told. And then we've got the issue of the misuse. So it was intentional, wasn't it? Because we know that the patient chose to put it in water because of the taste. So that does show it's intentional. And looking at the definition of misuse, or the description of the term misuse in the points to consider, we could see there the idea that it was intentional. It was for therapeutic benefit, but it was not in accordance with the label. So this would be intentional product misuse of sorts. Now, can we capture, it's not the dose that's changed, has it? It was the route. So we can see that it's intentional misuse, but do we capture also the route? Let's have a look and see our options for route. Let me just, before I do that one, I'll show you the hierarchy of intentional product misuse. There's nothing there in intentional drug misuse. Let's just go and have a look at the browser on this one. There it is. It's under product misuse, intentional product misuse. There's nothing there specific to route. So we ask ourselves the question, do we need to capture the route separately? So let's start with incorrect. See, incorrect route of drug administration, more specific than product administration. So again, right-hand click, go to the browser, and we can see it hit down here, incorrect route of drug administration. You saw that there was, there we are, what else have we got? Wrong route of incorrect route of product administration, drug administered via inappropriate route. So there's a selection there. We don't have anything that should be sublingual, but it's been taken differently. So this gives us quite a few. I've shown you there the options that we gave you. Let's go back now to our slides, and let's have a look further guidance in the points to consider companion document. Now this is looking at where prescribing errors or issues. We've got an example here. The drug was indicated for IV administration, and it was used off-label via the oral route. So here again, it's intentional, but this time it's off-label, which means it was intentional by the healthcare provider, by the prescriber there. So we would capture there the off-label use. Well, our situation is not off-label, is it? It's misuse. We've established that, but we also then would need to capture the route, because this example says that we should capture there that it was the inappropriate route. Intravenous formulation administered by other route with a PT of incorrect route of product administration. This provides additional information about the specific type of off-label use. Well, as I say, in our case, it's a misuse by the consumer, not an off-label, but it's the same situation. We then would need to capture the detail of the fact how it was deviating from the label. The term is not an off-label use itself, but it's a general product use issue term that can be used in combination with other terms to capture the detail about the off-label use, misuse, medication error, etc. So this is a point that we can apply to our scenario. just as a reminder there for you of the MEDRA hierarchy, this shows the difference between the product use complaint, and I showed you this live in the browser, and the product quality issues, terms like product aftertaste. So I was pleased to see in the multiple choice that most of you went for the product use complaint. So well done on that. As Carol Ann said before, you've obviously got some experience in these type of terms yourselves. Product taste abnormal is another one that would be in the quality issue. That was another one I gave you in the multiple choice that we wouldn't be looking for. So our learning points is always, particularly if you're new to this area of coding, reference the points to consider documents for guidance. Carol Ann and I still refer back to the documents now for examples to help reinforce our thoughts on the examples we show to you. This allows us to distinguish the different product use issues and concepts and where we need to split. And there also you can refer to the placement of related terms within the browser for guidance. And the last point is to distinguish, as I've just shown you there, between product quality concepts and product use complaints. When somebody says they dislike the flavor or the taste of a drug, that's not the same as saying the taste is abnormal, just that the patient has a preference not for that product. So our final suggestions here is the LLT dislike of product taste, as most of you chose, and also intentional drug misuse, because we know that the patient is doing it intentionally in conflict to the label. And the third one that we would select with this is drug administered via inappropriate route. As we saw from the example in the companion document, that gives us more detail about what the deviation was. So, any thoughts or comments on that one, Carol Ann?
Yes, we have some questions. One from Mohammed. He is asking, when would we use wrong technique in drug usage process instead of, yeah.
Wrong technique is it's more general, isn't it? And that would be an error, and medication. Well, would it be an error? Could you have misuse and then it being a wrong technique? You probably could if it was done intentionally, but our wrong route of administration is more specific than that because it tells us exactly what was done wrong. What would you say, Carol Ann? Would you have anything to add to that?
Wrong technique is more related to technical aspects of handling the medication, using the correct syringe or something like that.
Technique.
It's technique. It's technical aspects where you would use this PT. But here we have a clear scenario. So the patient is intentionally deviating from the label and in the context of therapeutic use of the product. So that's why it's not just an intentional use issue, it's just intentional misuse based on the definition of intentional drug misuse or product misuse.
Yeah, thank you. I think the route captures it nicely. It's more specific to what actually happened. Thank you. Any others, Carol Ann? You mentioned there were a few.
Yeah, somebody is asking whether this needs clarification because the subject using the product may be aware on the correct instruction and nevertheless decide to not do this. But I think this cannot be captured by MEDRA. So I think no clarification is necessary in this instance.
No, I wouldn't query this one because we're told it's because of the bitter taste. I don't think the reporter could give us any more information there.
Yeah,
Thank you for your comment.
And we have some comments where it stated that this may also be off-label use from the HCP, but I think this is not, if you see the whole context of the verbatim, this is not the case because it's clearly indicated that the patient deviates from the label because the bitter taste of the product. So it's a personal perception of the patient. I would not consider this off-label use in this instance.
No. I wouldn't see that as off-label. If the patient says to the doctor, it tastes bitter, and the doctor says, "We'll dissolve it," I wouldn't see that. I don't think that's what this is reporting.
Yeah, So intentional use by incorrect route would be a term that would capture the intentional use by the incorrect route, but it's not the correct assignment because it does not capture the misuse aspect. No. So that it was done in the context of therapeutic use of the product. So the definitions for these deviations for unauthorized product use, so deviations from the label, you should really be very familiar with, because there are really only slight nuances that really differ, and that where you have to classify sometimes as intentional use issue, and in other instances where you know that it's in the context of therapeutic use, there you have to use the intentional product misuse terms.
Thank you, Caroline, for your input. You're an expert on these medication errors and issues terms, Caroline, aren't you? Because Caroline does a specific webinar quarterly. So you'll notice there's some months where we don't have a Let's Code, and it's because we're doing a medication errors workshop and webinar that month instead. So Caroline leads these sessions. If you're interested in this area of coding, that might be something you want to look out for on our website. Come along to. So thank you, Caroline, for your input on this one.
There's one question whether we could also consider this a self-administration error.
Well, I don't think it's an error really, is it? Because it's intentional. So it is self-administration. You're right. It's a self-deviation from the label, but that's what our misuse definition gave us. So I think the misuse is the correct term based on what we saw in the PTC.
Mm-hmm.
Anything else to add before we move on?
Nothing to add.
Thank you, Caroline. Thank you very much, all of you, for your comments and questions. It makes it much more interesting for all of us. So now a different style of term. We've got a left non-functional kidney, not functional kidney. What does non-functional mean? I meant to update this one to non-functional. What does non-functional mean? Has the kidney ever functioned? So what I mean by that is, was it non-functioning from birth? Or has it stopped functioning? Do we need to seek clarification on this? Or what would, if you are going to code it, what would be the most appropriate LLT? Perhaps while you'd seek clarification or long term, what would be the best we can do with this one? Left non-functional kidney. So again, we've given you a multiple choice. Is it a renal function test? When they're saying it's not functional, does that mean it's renal function test abnormal? Renal function abnormal, which is a different term, not mentioning that a test was performed. Is it renal insufficiency if it's non-functional? Is it unilateral renal agenesis? So a developmental problem where the kidney hasn't developed properly, and that's what's meaning it's non-functional unilaterally because we know it's left. What about the term solitary kidney? Or would we seek clarification? So I'm seeing the votes. I sense that maybe only about half of you are voting. So if there's some reason why you don't wish to vote or you can't vote but you'd like to, let us know what we can do to make it easier for you if you're having trouble, or a bit more than half. Maybe some of you are still thinking. It's completely anonymous, so feel free to join in if you're test yourself on what you think. Let's see how our votes are lying so far. So the majority of you, or just under half of you, perhaps I should say, are seeking clarification from the reporter. That's the most popular option so far. Few of you are going for renal function abnormal, renal insufficiency, and solitary kidney. So I think it seems like about half of you would query it. And perhaps in the meantime also select a term. So function abnormal because we're told it's non-functioning. Renal insufficiency, which is a form of renal failure there, or solitary kidney. So let's have a look at where our final votes is number one to seek clarification, and then renal function abnormal, which is interesting. So let's have a look at referencing of this one. So when we did some referencing, and we found this reference here, and we've got it there from NIH in the US, a reference said, one important condition in the spectrum of congenital kidney anomalies of the kidney and urinary tract is the solitary functioning kidney. So this is saying that often it might be congenital, or it could be acquired after unilateral nephrectomy in childhood. So this is looking at either congenital or acquired during childhood after a nephrectomy, but could be later in life as well. So this is telling us that we can't assume it's necessarily congenital. It could be acquired. We don't know the age of the patient or when it stopped functioning. Although both types of solitary functioning kidney are associated with chronic kidney disease and end-stage renal disease, so renal failure in other words, early differentiation between patients with and without an increased risk for renal failure is challenging. Because of the implementation of routine fetal ultrasound screening in most developed countries, patients with a solitary functioning kidney are increasingly identified before birth. So it can quite commonly, it seems, be congenital, but not exclusively so. So let's browse. So we'll have a look here for let's look at the hierarchy for some of the terms we had in our, let's look at renal function abnormal, and we'll get the test abnormal and the abnormal term, the two that we had. So let's just show you here. We've got renal function abnormal, which goes under renal impairment. Renal failure impairment is the HLT, and that's in the renal and urinary disorders SOC. We've then got the renal function test abnormal, but our verbatim hasn't told us that tests have been done, have they? We would assume that some have been done. Renal function abnormal, renal test function kidney abnormal, that'll be a synonym. Renal function abnormal, renal function test abnormal, there it is, that's the one we had in our multiple choice. Well, this is very clearly a test result because this is under the investigation system organ class, and that isn't really what I feel we've been told here. We've not been given the results of a test, nothing specific, although some tests must have been done. So the renal impairment seems a better area to go, but there are others that we could look up. So let's have a look at the solitary kidney, because that seemed like it had a very clear definition with it, didn't it, from the reference. So let's have a look at, see what this one is in MEDRA. So we've got solitary kidney, which is under a PT of single functional kidney, renal disorders, and it is in renal and urinary disorders. So what I'm pleased to see there is that this solitary kidney term doesn't automatically assume that it's congenital, where perhaps the renal agenesis would have done. We'll check that in a moment. And then we've got solitary kidney secondary, as if it's following some other condition, perhaps, that there's a solitary kidney, and that has the same PT, single functional kidney. So I can go to the browser to check this out further. Here, single functional kidney is the PT, and we can see it's under the HLT of renal disorders, not elsewhere classified. So it isn't assuming it's either congenital or acquired. Kidney absent, single functional kidney. Well, that's a nice looking term, isn't it, for what we've got? We've been told the left is non-functioning, so single functional kidney looks like quite a good match to what we've actually got reported. Remember, we always do code as reported. So I like the look of that one, solitary kidney, rather than the renal function abnormal, because it's specific to the fact that one kidney isn't functioning at all. So I like the look of that one. What else do we look? We can look at the renal agenesis, just to see the hierarchy of this one. We haven't been told that the kidney hasn't developed. That's not what we've been told. Renal agenesis, unilateral renal agenesis is under renal aplasia, that it hasn't developed. And we haven't been told that. If I put my cursor on it, we can see on the right-hand side here, that's primary to the congenital SOC. Well, that wouldn't be what we have reported. We don't know that. We can't make that assumption. So that's a term I would discount. So I think that gives us a bit of And the other one would be renal insufficiency, which I think will go up in under the renal failure hierarchy. Is our other option, renal insufficiency. Let's look at all the options. Renal insufficiency is under renal failure and impairment. So that there we can see is in the renal disorders, system organ class renal, but I think we can be more specific than that. I like the look of the term, the solitary kidney. So let's go and see what else we can research. Well, in terms of investigations, I gave you the option at the beginning, maybe it's a renal function test term, but we would say here that if you do have the results of investigations and they're clearly a test, for example, increased, decreased, abnormal or normal, that's not what we've been told. We haven't been told that the function is abnormal for that kidney. We've been told it's not functioning. So it's more of a description of the kidney. And so as the points to consider says, when it's got clearly a test result, you would code it to a term within the investigations. But when it's a condition or a description of the anatomical state, then you would link it into the SOC that relates to the body system. So this is a points to consider guide to bear in mind. So we would then distinguish the test results from the corresponding diagnosis, consider the context in which it's been reported, and in particular the age of the patient. So the context, we may know why, may know other underlying conditions or prior operations that have been performed. Consider the age of the patient so that you can then make a judgment, is it congenital or acquired, and select the appropriate LLT there. Refer also to the placement of related terms for guidance and query if the meaning remains unclear. So this is where a number of you are going to query, and that is what we would suggest. Firstly, we would say query it to get the age information, and if no further information does become available, we would select the LLT. We would select solitary kidney with a PT of single functional kidney. And you saw that most importantly, I checked the hierarchy to make sure that that wasn't a congenital term and I wasn't making an assumption. Because the point to consider document tells us that if you have the option and you don't know which it is, it's better to go for the acquired form. So any questions or comments, Carol Ann, on that one? Have our group got any thoughts on the example?
We had some feedback that some of our attendees would prefer to go to single functional kidney. Because it's closer to the verbatim and it's well taken. Yeah.
Yes, I agree. That was my thought too when I was looking. So yes, that was. I think we're right there. It's just solitary kidney.
Solitary kidney can be considered a synonym of single functional kidney, but of course the single functional kidney is closer to the actual reported verbatim.
I agree. Look at this one again. Yes. Thank you. Good, thank you very much. So my third example, before I hand back to you, Carol Ann, is nasal respiratory insufficiency. So what have we got here? This was a suggestion that came from one of our attendees at a previous session. And I must admit, when I saw it, I thought, well, what is this talking about? Nasal respiratory insufficiency. Well, I'm familiar with respiratory insufficiency, but nasal? What's actually being reported here? Is there something else underlying that they're not telling us in this? Is it clear enough to code? Should we clarify it? Or is there an appropriate LLT that we could find for this? So what would you do? Here, we're not making it so easy for you. What would you do with your coding? Can you suggest a term here? How would you handle it? Nasal congestion. What does it mean? Insufficiency. Well, what does the nose do? It lets air in, doesn't it, for respiration? You're breathing through your nose. And it seems that process, seek clarification, nasal disorder. That's a general term. If you don't know, nasal obstruction. You query for additional details. So insufficiency, respiratory. Well, is it respiratory insufficiency? Interesting here. A couple of you there going for respiratory insufficiency. This is where we'd like to unmute all 130 of you so that you could debate it online perhaps, but it might be a bit of a a difficult conversation to follow. Seek for clarification. Upper respiratory disorder. Now, interesting there, you're focusing there on the site, that it's nasal. It might be sinus. Somebody is suggesting sinonasal. Could be an allergy, but we haven't been told that, have we? It could be congestion. It could be a lot of things. A few of you have said obstruction. So let's have a look. Let me go on to our next. Thank you for your input there. So we tried to reference this, and the only reference we could find dated back to 1940. And it did mention nasal respiratory insufficiency from a medical journal. And it said that nasal respiratory insufficiency is the state in which it is impossible or difficult for the individual to procure through the nose alone the amount of air necessary for satisfactory lung ventilation. So it's not saying there's anything wrong with the lungs. As somebody highlighted, it's the upper respiratory tract that has the problem. We don't know why, but it's impossible or difficult to procure through the nose alone the amount of air necessary. Well, the nose itself, I don't think does anything in terms of the access to air other than it's a channel. So I agree with most of you that I think it would suggest some kind of blockage or obstruction. So let's have a look, but it could be anything, couldn't it? That obstruction could be anything really. So let's have a look. Should we go for nasal? Let's try for nasal insufficiency first. You can see I tried this when preparing for the nasal nothing with insufficiency. We've got respiratory insufficiency, but I have a nagging feeling that this is not what's being reported. Respiratory insufficiency goes to respiratory failure. Well, that immediately I'm thinking, no, that's not what's reported here. They're not telling us that the patient has respiratory failure, that they're not able to breathe, just that they can't breathe through their nose. So no, I don't like that, respiratory insufficiency. I have a real gut feeling that that's not right. So let's look at nasal obstruction and then go across and see what else we have some of you suggested nasal obstruction. There must be some kind of obstruction there to give us the fact that the air can't get in. So let's go to the browser and have a look. I mean, it could be, we've got nasal obstruction, or some of you said nasal disorder, which if you're not happy to go for the plump for the fact there is an obstruction, I tend to think it would be some kind of obstruction. There's nothing else specific under that LLT, but then we're down to, well, are we saying it's nasal swelling, nasal congestion? Could be some kind of polyp or tumor, or it could be anything, couldn't it? Could be cyst or congestion. So I could be here all day looking at different options. So I think we're down to either nasal obstruction or nasal disorder, because we've seen from the reference that the problem is with the nose, not with the lungs themselves. Upper respiratory tract disorder would be more general when we're told it's the nasal insufficiency. So I think there I'd be looking for referencing medical literature as you saw us do, although there wasn't much available. Then browse for a suitable LLT that looks for the site and the condition. Well, we don't know exactly what the condition is, but whether we can assume that it is some kind of obstruction. Look at the placement of related terms and taste the best approximation approach. So there we would be looking for nasal obstruction. And another idea we've given you there is mouth breathing. Now let's have a look just before we go that one. I didn't look at this one here. We've said that the patient isn't able to breathe through their mouth, through their nose. So this means that if they are able to breathe, they must be breathing through their mouth, because the reference said they're not able to breathe through their nose alone. And this is under a breathing abnormality, respiratory disorders. This is more what we've been told, isn't it? It's a breathing problem rather than a respiratory failure. So that's another option you might want to look at there, mouth breathing, a style of breathing. I forgot to look at that one when we were doing our browse. So any thoughts on that one, Caroline? Any comments from the group on that one? Does the group think obstruction is an assumption? Are they still wanting a disorder term? What's our comments?
There are no comments in this regard. One is coming. Since nasal respiratory insufficiency doesn't necessarily mean inhibited nasal respiration, would mouth breathing be the best option?
Yes, that's what, when we were talking them through, that's what you suggested, Caroline, wasn't it? That mouth breathing is an option. That's why we've put it here on our final suggestions, that we've put and/or nasal obstruction and/or mouth breathing, because what you're told is they can't breathe through their nose. So without being told that they're not breathing, we would assume they are mouth breathing. So you could choose that one, yes.
Yeah, there's no single correct solution in this instance. So you could also argue and say, well, the nasal respiratory insufficiency is definitely due to a nasal obstruction of some kind. It's not specified, and that the mouth breathing also indicates the severity of the condition because it's considered an insufficiency. So it's quite a severe inhibition of breathing through the nose. So that's why you could either split into nasal obstruction and mouth breathing, or you could only assign nasal obstruction. Severity would be captured in a separate database field then, and the mouth breathing would, this is not as specific because mouth breathing could of course also happen if you're under stress, must not always be related to a nasal obstruction.
No, definitely not. Could be exercise, could be under stress, as you say, Caroline, or habit. Yeah. Good. Well, thank you for your input on that one. Thank you, Caroline. I'll hand over to you now for our next set of 3 examples.
Yes, I will show my screen then again. You see it?
Yes.
Okay. So here we are. And this is our next example. We have a restriction of respiratory function due to lack of regular physiotherapy after hospitalization. Is the reported event clear, or do we need clarification here? And should we try to capture the lack of physiotherapy? Can we capture this at all with MEDRA? Would split coding be needed? So how should we handle this report? Could you show the QR code again, Jane, please? I can do so. Here it is. Somebody was asking for the QR code because she lost the connection. Here it is. I hope you can scan it with your mobile phone. So here we are. So, and what are you going for? So most of you would go for restrictive respiratory insufficiency, restrictive pulmonary disease, lung function decreased, respiratory compromise. Some of you would go for hypoventilation as well. And some would seek for clarification. But restrictive respiratory insufficiency seems to be the most popular choice here. So let me close it. Thank you for joining. Here we are. And again, we will first have to clarify these terms. So respiration, when looking into the definitions in Dorland's, you will find a description there. This process includes the ventilation, in other words, the inhalation and exhalation, as well as the diffusion of oxygen from the alveoli to the blood and CO2 from the blood to the alveoli, plus the transport of these gases to and from the body cells. It is a broad term, respiration, and for a normal respiratory function, not only the upper and lower airways are relevant, but also the musculoskeletal structures, which allow for movements of the thorax. Restrictive, relates or refers to a limitation, in our case, a limitation of the respiratory function. And when seeing similar verbatims, which contain the information respiratory and restrictive, you may immediately think about restrictive lung disease. But this term is more specific. It relates to a pulmonary disease. Restrictive lung diseases lead to a decrease in the volume of air and amount of oxygen that a person inhales into the lungs and can finally supply to the body cells. Now, we also saw several terms for clinical signs and symptoms for a restriction of the respiratory function. Hypoventilation is a state in which there is a reduced amount of air entering the alveoli. So this was not reported in our case. We would add information when selecting this term. The respiratory restriction or limitation could be due to a problem in the upper airways as well. And hypopnea is too specific as well. The term stands for an abnormal decrease in the depth and rate of breathing. Again, we don't know that. It was not reported. Dyspnea is a more general term and stands for difficult or labored respiration. It could be considered because it is more vague than the other two terms, but again, it was not reported. We don't know whether the patient is suffering a dyspnea. Maybe the restriction of the respiratory function was only detected by tests of blood gases, for instance. And also dyspnea may have different etiologies, not just respiratory disorders. So in my view, none of these terms would adequately capture what is reported in our verbatim. Now we come to the physiotherapy. The patient should have received chest physiotherapy to improve or sustain the respiratory function. However, due to unknown causes, he or she did not receive this therapy. So can we capture this with MEDRA? Unfortunately not, because such a scenario is out of scope of MEDRA. We could capture like financial problems or insurance issues or therapy non-compliance with MEDRA, so which could lead to missing the physiotherapy. But we don't know the reason for not getting the physiotherapy. That's why we cannot capture any information that is related to this missing of the physiotherapy of the patient. Now let me again go to my browser here and look at some of the proposed terms in the poll. So restrictive respiratory insufficiency. Many of you voted for this term. Here we are. And if I look into the hierarchy, go to the browser here, respiratory failure would be the PT here. And if you look into the LLT content, end-stage lung disease, hypoxic respiratory failure, respiratory insufficiency. So this is a much more severe condition than what has been reported in our verbatim. In our verbatim, we are only told restriction of the respiratory function. We don't know the severity of this restriction. So coding this to a failure term would assume that this is a very severe, even serious condition. Now, respiratory failure or restrictive, here we have the restrictive respiratory insufficiency would not be appropriate. So let's look for other terms that we could see in our in this grouping here, but it's all failure. So none of these are suitable for our coding purposes. We already said that restrictive pulmonary disease is too specific. We don't know whether the restriction of the respiratory function was due to a pulmonary disorder. It can be caused by any disorder in the respiratory system. And now look, we can look for lung function and decrease. Oops. Me and my typo errors. Lung function decreased. Here we are. If I click on it, you see it's grouped in SOC investigations. The verbatim does not make clear that the restriction of respiratory function was revealed by an investigation of the respiratory tract. So the verbatim could also relate to a vague diagnosis. So this would not be appropriate. Respiratory compromise was another option. Here we are. It includes the string respiratory and also conveys the fact that there was a restriction, a limitation of the respiratory function, compromise. So, and this LLT is grouped under quite vague PT respiratory disorder. And we also already talked about the LLTs dyspnea, hypoventilation, and hypopnea. So all separate PTs, dyspnea, here we are. Going to the browser, you see that it's grouped under breathing abnormalities. Here it is, you have breath shortness, breathing difficult, gasping, hunger, air hunger, respiration labored. This was not reported. And the same holds true for hypoventilation. We saw the definition. It's not appropriate for what has been reported here because we don't know whether the lung capacity was actually affected. So whether it's really an alveolar hypoventilation. So this was not reported. And the same holds true for hypopnea. Again, a separate PT. Here we are. Let's go to the browser again. Here it is. So here we have LLTs like breathing shallow breathing, respiration, spontaneous decrease. So this is nothing that has been reported in our case. It was just a very unspecific report on a restriction of the respiratory function. Now let me switch back to my slides. Here are the learning points. So first of all, we should not make a diagnosis like restrictive lung disease from a non-specific descriptive report. We also should not assume that a given report represents a result of a diagnostic procedure, a test result, unless clearly stated. And when dealing with combination terms, always consider whether more than one LLT is needed to capture the full information. In this instance, this was not the case because the reported reason for the restriction of the respiratory function in this patient is out of scope of MedDRA. It cannot be captured with MedDRA. So the lack of physiotherapy in this instance. And here are our final suggestions. Some of you have also voted for seeking clarification for this verbatim, because this is a vague report that could describe a quite severe or even serious respiratory condition. It may affect the lungs, and these represent a vital organ. So therefore, we would first query to get more information about the exact etiology of the respiratory restriction or more details about the respiratory restriction. And if no further information becomes available, we would prefer to assign a vague term like LLT respiratory compromise under PT respiratory disorder. This would then best reflect the vagueness of the reported condition without making any assumptions. And it would capture the limitation of the restriction of the respiratory function in an adequate way. Any related questions, Jane?
No, I think the only other suggestion is respiratory dysfunction. Respiratory dysfunction, so a general term, a bit like your respiratory disorder.
Yeah, this would also be an option. Yes, let me again check in the browser. here we have the respiratory dysfunction. Go to browser. It's also under respiratory disorder. So same PT would also be an option. Yes, I agree.
And now another one here, post-operative respiratory distress. But so looking at our verbatim, just to remind you, restriction of respiratory function due to lack of regular physiotherapy after hospitalization. So I'm not seeing an operation in that one, but I don't know, Carol.
No, it's not. No, it's suggesting, it would suggest that there was a surgery performed during the hospitalization. We don't know that. Maybe the patient was just immobile during hospitalization and therefore needed the physiotherapy. We don't know whether he or she underwent surgery during hospital stay. It would be an assumption. Anything else?
No, those are the only comments, Caroline. So you've probably got time to fit in another one, at least one more.
Yes, I will do.
Good, thank you.
And it's a more straightforward one here. It's easier to handle. So it is reported that a patient suffered an acute hypoxemic and hypercapnic respiratory failure. Do we understand what is being reported, or do we need to query? And is this one event or is it two events? Do we need to split code and select two LLTs for this verbatim? What do you think? Here we have our options. How would you code this report? Would you assign LLT acute hypoxic respiratory failure, or would you assign hypercapnic respiratory failure, or respiratory failure, or acute respiratory failure? What would you do? I see that many of you are voting already. Now let me check what you are voting for. Here we are. Most of you are going for acute respiratory failure. Others would select acute hypoxic respiratory failure. Others respiratory failure and hypercapnic respiratory failure. So split of opinions here. Let me close the poll and show you some definitions here from the website of the Critical Care Medicine at McGill University in Montreal. So we see that acute respiratory failures can be classified as follows. So there is a type 1 respiratory failure, the hypoxemic failure, and this is a clinical picture that can usually be seen in patients with acute lung edema or acute lung injury. Then we have the type 2 failure, and this is characterized by hypercapnia and is usually seen in patients with breathing difficulties due to airflow obstruction or decreased respiratory system compliance with decreased respiratory muscle power due to neuromuscular disease, for instance, or with central respiratory failure and decreased respiratory drive. Type 3 is a perioperative condition and represents a subset of the type 1 failure, and type 4, the shock respiratory failure, is caused by the shock secondary to cardiovascular instability. Now, our patient suffers from both a hypoxemic and a hypercapnic failure, so both from type 1 and type 2 acute respiratory failure. Let me again switch to my browser, and this time I will do an advanced search here, and I would look for both the hypercapnic failure or the hypoxemic failure and see what we get here. And we see that there is an acute hypoxic respiratory failure, LLT, and two LLTs, hypercapnic respiratory failure, hypoxic respiratory failure. If I click on one of these and go to the browser, I can see that both are grouped under PT respiratory failure. Here it is. Here we have the hypercapnic respiratory failure and the hypoxic respiratory failure, both grouped under respiratory failure.
Caroline, while you're there, we've had a question about the type 1 and type 2. Somebody's suggesting type 2. Could you explain those two while you're there?
Yes, the type 2 is the, I just showed it in the definitions of the McGill. So there can be, respiratory failures can be classified in 4 types, either hypoxemic or hypercapnic. Hypoxemic would be the type 1, hypercapnic would be the type 2, and then the type 3 and 4. So the 3 would be the perioperative, the type 4 would be the one that is related to a shock status of the patient. So type 1 would be the hypoxic respiratory failure. It's just a different term for it. It's a synonym. And the hypercapnic respiratory failure would be the type 2.
Thank you.
So we have both of them under respiratory failure. We don't have the type 3 or the type 4 respiratory failure. But what is missing here is the information acute. The acute is of course relevant to know. It's not captured with this PT, and this is of course medically relevant information. So if we look into this HLT respiratory failures, you see that there is a separate PT acute respiratory failure. And if I open this one, I see that it contains an LLT acute hypoxic respiratory failure, but there is none for hypercapnic. We have the type 3 here. The type 3 perioperative respiratory failure is considered an acute failure because it's in a short time frame due to an operation, but otherwise we do not have any further LLTs that would relate to this classification. Not like we have in the respiratory failure PT, where we have both the hypercapnic and the hypoxic respiratory failure LLTs. So what shall we do now? Based on what we can see here in this in the MEDRA classification, we see that the type of respiratory failure, whether it's acute or whether it's chronic or whether it's unspecified, is considered more important than the different subtypes, because the subtypes here, type 1, type 2, are just grouped under respiratory failure. So the most important information, medical information that we have to capture is the acuteness of the respiratory failure. And here, because we have the acute hypoxic respiratory failure, you could of course select this LLT, but we have more information. We know it's not only an acute hypoxic respiratory failure, but it's a mixed picture of a type 1 and a type 2 acute respiratory failure. That's why, in my view, selection of acute hypoxic respiratory failure would not be appropriate, but I would take the same approach as here with the respiratory failure and just assign acute respiratory failure. Now let me switch back to the slides. Some of you may have considered split coding, but we could see that the information about hypercapnic and hypoxemic respiratory failure is lost on PT level. So the main difference on PT level was the distinction between acute and unspecified respiratory failure. The MEDRA term selection points to consider document provide some guidance in this respect. We are told that splitting the reported adverse reactions or adverse events provides, if this provides more information, we should select more than one MEDRA term. But we should always exercise medical judgment so that the information, first of all, is not lost when splitting as reported, and we should always check the MEDRA hierarchy above the selected term to be sure it is appropriate for the reported information. So there's one example in the document that supports our view to just select one LLT for such a scenario. In section 373, we are told that if the LLTs representing the medical condition all link to the same PT, we should select a single LLT that most accurately reflects the reported event, meaning that capturing the underlying event information has priority. This is all illustrated by a medical condition which affects more than one body site, here a skin rash. So if a skin rash on face and neck is reported, we should not split into rash on face and neck rash and LLT skin rash, because they all link to PT rash. We should just assign skin rash to capture the information that the skin was affected, but we should ignore the affected sites, just assign skin rash, not split, because all of these LLTs are linked to only one PT. So this rule is of course also applicable for other scenarios like ours, for our reported scenario as well. So these are again the learning points. First, look for the LLTs which would capture all reported information, then check the hierarchy of these LLTs and apply the relevant guidance in the MEDRA selection points to consider document that we just saw. So with this, our final suggestion is to code this verbatim to LLT and PT acute respiratory failure. So we would ignore the hypoxemic and hypercapnic aspect, but we would capture the acuteness of this respiratory failure, because this is represented in a separate PT. Any questions, Jane?
No questions, Carol-Ann. No questions or comments on that one at all. You've dealt with it already. Thank you.
Thank you. Then I hand over to you again.
Thank you. I'll just wrap up the session. I see we're out of time again, unfortunately. I'm sorry that we've not covered all of the examples we brought along. We will carry them over to our next session, which is in July, isn't it, Carol-Ann? July. So yes. we'll just, and if you haven't joined us previously, I just want to remind you that we do record the sessions and there's a repository of them on our YouTube channel. So you can look under the playlist. If you look under, you go to the MEDRA MSSO YouTube channel, there's a playlist specifically for these Let's Code sessions. We've been doing them now for about 18 months, so there's a number of sessions there. And there's also a document on our website, which is an index document on the training materials page. So we can't store all of these recordings on the training materials, but we do have an index. So this allows you to look at the particular types of verbatims. You can look by therapeutic area or by principle, coding principle, and to see the examples. And that may help you decide which one of the recordings you want to start with. So that's just a reminder there for you if you are new to these monthly sessions, as I say. And then we have a survey, which I see, thank you so much, 46 of you are already underway on that one. Give us feedback on what we've done today. This is also your opportunity to suggest specific MEDRA terms or therapeutic areas or particular examples, types of terms that you'd like us to cover. We were a bit slow today, apologies for that, but normally we try to cover more examples. And so we welcome your input on this for the survey. You'll also receive a different survey by email after the session, so you can choose either one to give us your feedback on. That's fine. We really appreciate your feedback. Carol-Ann and I take on board what we can of your comments, and we're always looking to improve ourselves. Sometimes it's difficult because we have somebody saying, make it longer, make it shorter, add more examples, don't do as many examples, go faster, go slower. We have conflicting. So we do what we can where there are pieces of feedback we can implement. Okay, so just as a wrap up, here are the contacts for you to our website for the browsers, the email address for the help desk, and the website. There's this training schedule if you're interested in Carol Ann's medication errors session or the upcoming Let's Code next month. In June, you can sign up there. And there's also links to the support documentation, some of which you've seen us share with you today, the points to consider, term selection document and the companion guide. So with that, here's our contact page. If you do want to contact us, you've got our email addresses, and there's a contact page where you can join a WhatsApp group, you could do a live chat with us, or you can email us at the help desk. So that's all our topics for today. So just to thank you for your attention today. Thank you for your participation. Makes it so much more enjoyable. Carol Ann, thank you for your collaboration and all your expertise that you bring to these sessions. It's always a pleasure to work with you on these sessions. Great fun to do them. Thank you for that.
Same true for me, Jane.
So enjoy the rest of your day, everyone, wherever you are in the world. And I'll look forward to seeing you next month at the next session, or in July, I should say, for the next session. Bye-bye for now, everyone. Bye-bye.
Thank you all. Bye-bye.